All right, so now let's get into hearing. I felt obliged to include some images of foreign objects in people's ears. Do you say why I did that? Why not? Because it happens to people. It happens a lot. It happens a lot to a lot of people. And spiders, all sorts of weird things can wind up in the ears. So there's another video I'm going to show you guys in a little bit. It's pretty awesome. And I think the spiders are kind of cute, honestly. Yeah. Especially like the little jumping spiders. So we're going to talk about how the properties of sound, frequency and amplitude. We're going to talk about different types of hearing loss and how you test for it. And I totally forgot to bring my tuning forks because I have tuning forks in my office, so you can do like the Weber and the Renee's test. Yeah, man, I might do that. I might bring them in on Thursday just so we can go through those because I think it's kind of fun. We're going to talk about the anatomical and physiological function of the ear. We're also going to talk about tonotropy or tonotopy, frequency maps, as well as how you encode sound frequencies. So, anyone see this movie? Extra credit for anyone who knows what movie this is from.
Back to the Future, but I've not seen it. Is that right?
Yeah, it is Back to the Future.
You extra credit?
No, I was just joking. But it's a good movie. You should see it. It's awesome. Have you guys all seen Back to the Future? Yeah? Except for you? All right. You got to step up your movie game, my man. All right, so here's the overview of the entire auditory system. You have your outer ear, which is basically just the ear canal. And then the tympanic membrane is what divides the outer ear from the middle ear. Within the middle ear, you're going to see three different bones, malleus, incus, and stapes. And then you're going to see how the stapes connects to the cochlea, and that's going to be what allows you to hear, right? So you basically vibrate the stapes, and that's going to transmit sound into the cochlea, which can be perceived by the cochlear nerve, right? So you got the vestibular cochlear nerve, right? Cranial nerve 8. You got the vestibular component, which is associated with the vestibular system, aka balance, right? We're going to talk about that in particular next time. And then the cochlear portion, which allows for actual hearing. And your ears are connected to your oral cavity, right? So you have the eustachian tube, which is connects to the nasal pharynx, basically. So.
Isn't that what causes ear infections?
Yeah, absolutely. So, for example, my wife, when I got bronchitis over the winter break, I gave it to her. So, Merry Christmas. And then she got an ear infection, right? Because when you have like a respiratory tract infection, that can easily make its way to the ear, to the eustachian tube. So, absolutely, yeah, they're connected. I'm not going to play this video. Actually, you know what? It's pretty short. Let's go ahead and watch it. BBC. Why not?
Inside your ear, sounds set off a complex chain of events. They enter as pressure waves, which push and pull your eardrum, making it vibrate. On the other side of the eardrum, these vibrations set a series of bones jiggling. They end with the smallest bone in your entire body, called the sternum. It is smaller than a grain of rice. These bones allow you to hear. If a sound is too loud, a muscle pulls the stirrup away from the most sensitive parts. Temporarily at least, you go a bit deaf, but the rest of your ear is protected. Beyond the stirrup is a fluid-filled cavity, your cochlea. The incoming sound waves tickle clumps of tiny hair-like sensors on the floor. These begin to dance to the sounds of the world outside. You have 30,000 sensors. Each picks out a different part of the sound and sends it straight to your brain.
All right. So that video is actually really cool. I'm glad we played it. Cool. So here's the properties of sound. So it's going to be producing a sinusoidal type wave pattern. Now, in terms of pitch, that's going to be the frequency. So low frequency is going to be, for example, if you play the piano, the low notes are going to be low pitch, right? So low frequency. So if you go to like the lowest C on the keyboard, it's going to be low frequency. If you go to the highest C, it's going to be high frequency on the keyboard. Versus loudness and intensity, that's measured in amplitude. So in other words, the size of the wave. Frequency is measured in hertz versus loudness and intensity is in decibels. Right? So you can actually get decibel recording devices to see if you're making too much noise in your house or if your neighbors are making too much noise. I forget what the level of decibels is because when I was living in New York, we were all kind of like, we live on top of each other like sardines and whatnot. And I remember moved into my apartment. I was super stoked. I came back from a long shift at the hospital. I play music, so I play accordion as well. So I started playing my accordion when I got back. It was 6 p.m. Like within literally 1 minute, I started hearing the broomstick beneath the floorboards. I'm like, what the hell? And I didn't stop. I just started playing louder. And then shortly after that, the lady comes up, knocking on my door, and she was like, "What the hell are you doing? Playing the harmonica? What is that?" And I'm like, "It's an accordion." And she's like, "You gotta stop playing." I'm like, "It's 6 o'clock in the afternoon." She's like, "I just got back from work." I'm like, "So did I." I'm like, "It's 6 o'clock in the afternoon." And she's like, "I'm gonna call the police." I'm like, "Go ahead." And I was like, shut the door on her. And I looked it up because I was kind of concerned. I was like, if she does call the cops, am I going to get in trouble? So I looked it up and I looked up decibels. They actually have if the cops do get called for a sound complaint, they actually have devices that they can bring and to see if the sound outside the door or outside whatever, the walls are actually loud enough to warrant a citation. And so I was thinking about getting one of those devices to actually record this, how loud my accordion was. I never did. I think after that day, if I remember correctly, she never complained again. So, yeah, New York, man, it's tough. You got annoying neighbors. My neighbor upstairs recently got mad at me for playing the guitar too loud, but it was at 10:30 at night. I think it's reasonable, right? Even though sound ordinance in Phoenix, I think it's 11 p.m., so he wouldn't necessarily have a legal case to call the cops on me. But anyways, I'm a terrible neighbor, I guess. Did I stop? He did the same thing. He was bashing on the ceiling, and what I did is I turned up my amp. When someone tells me not to do something, I usually do the opposite. So I know I'm a feisty neighbor. Anyways, and he's rearranging furniture in the middle of the night. He's woken up my wife and I multiple times. It's he's this tall giant, and you can hear him just fee-fi-fo-fumming throughout his apartment. And he's got a dog, and the dog's I don't know, tap dancing. Anyways, yeah, no, I wrote him a lengthy, a strongly worded letter about the rearranging furniture in the middle of the night. So, anyways, total digression. Power spectrum. This is how you visualize frequencies.
Given a time series, we can break down the signal into the weighted sum of sine waves.
This is the Fourier
Here I'm
transform.
showing 12 most
Sorry?
important components
This is the
of
Fourier
signal.
transform.
Each one has 3 features: frequency,
Calculus I was talking
amplitude,
about?
Oh, that's what that is. Yeah.
Frequency and amplitude of each component plotted against its frequency. The most important frequencies have similar weights, but as we add in the other frequencies, we get the entire power spectrum. Note that the phase information has been discarded. We can smooth it out a bit, and now by taking the logarithm, we get the log power spectrum, which tells us the relative importance of each frequency component to the overall signal.
And you can break up each individual frequency. So pretty fun stuff. If any of you guys ever recorded music on Logic or even Bandcamp, you'll see this type of these patterns, right, when you're recording music. So cool stuff. So you said Fourier sequences or frequencies?
Fourier transform. So it's what
Trans-
you can do in calculus is take all the frequencies of stuff and then you do that and you basically separate them.
Yeah.
So that's what I was saying with my theory of your bodies might be doing that. If you're
Interesting.
next to somebody.
Interesting. Okay, that's cool. I love that. All right. So again, the sound is going to operate in a sinusoidal type pattern. So here's a couple of examples of how they broke down different sound waves and frequencies. Here in B, this is the sound coming from a rhesus monkey. You can see the different frequencies that are going to be portrayed in there. And if you broke it down in a spectrogram, you can see like the different frequencies broke down. So cool stuff. Stuff that I'm not going to test you on, but it's fun regardless. So again, here's another spectrogram. So you're going to see the different types of sounds, especially coming from animals, from musical instruments. Compare that to the wind, right? Things like wind or just background sound, it's kind of boring, really nothing much going on there. Versus speech, versus music, versus animal sounds, those are going to be much more interesting. They're going to have more like tonal and harmonic elements associated with them. Now here's the overall frequent audible spectrum. Note here I highlighted the human spectrum of perceived sound. Other animals have different spectrums of perceived sound, right? Dolphins, for example, they can hear way higher frequencies. Fish can have different frequencies, so we all have different frequencies. With humans, it's going to be 20 hertz to 20 kilohertz. And that over time changes, right? As you get into adulthood, you're going to actually start losing some of the higher frequency sounds, which I'm going to play in a really interesting video. That's kind of part of presbycusis. Presbycusis is the natural loss of hearing as you age. So the older you get, you're going to start losing certain frequencies. Lots of people in the United States have hearing impairment. So 48 million Americans have hearing loss. So that happens to a lot of people, right? And it's going to be age dependent. So 75 and older, 50% of people are going to have some form of hearing loss. Between the ages of 65 to 74, 24%. So the older you get, the more hearing loss you get. Guys are going to be more likely to lose their hearing compared to women, whereas women are going to be more likely to actually disclose their hearing loss, right? Guys usually kind of suffer in silence, I guess, is one way to look at that. Actually, I didn't mean that. I didn't mean that to be a pun. That's pretty funny. Anyways, hearing loss. What are the things that can affect your hearing? Trauma, obviously, can affect your hearing, right? Certain drugs can affect your hearing. Aminoglycosides can cause tinnitus. There's a bunch of drugs that can cause tinnitus. Aspirin, for some people. Just aspirin can cause tinnitus in some people. Diseases, arthrosclerosis, autosclerosis, which we're going to talk about in a second. Presbycusis, again, that's just aging. And some people just have a genetic predisposition. Peripheral monaural hearing loss. So that's involving transduction. So that's going to be involving middle and inner ear. You can also have hearing loss due to issues with the central nervous system, like the brainstem. You'll especially see that resulting in bilateral hearing loss. Now, there's two major categories of hearing loss. There's conductive hearing loss versus sensorineural hearing loss. With conductive hearing loss, think about earwax, right? This happened to my dad like about a year and a half ago, maybe 2 years ago. He was like, even when I was driving with him in the car, like sitting right next to him, just trying to talk to him, he wouldn't hear what I was saying. So he was having some serious hearing loss, and it's because he had cerumen buildup in his earwax. Took him to the ear cleaner, ear doctor. They removed the earwax, and he can hear just fine now.
Have you ever gotten it cleared out?
I never experienced that. I keep my ears pretty clean in general.
I think when I was a kid, I had a problem, and they did that, and I remember it being so painful, but I could hear the world.
Once it removed it, you could hear everything, huh? Yeah, that's awesome. That is really awesome. So think about conductive hearing loss as being something that damages the ability for vibrations to make its way to the middle ear. So it could be due to occlusion, earwax. It could be due to damage of the tympanic membrane. It could be ossifications of those bones in the ear, aka the stapes, the incus, the malleus, any of those. Sensorineural hearing loss, on the other hand, is going to be more associated with like the neuronal components. So it could be congenital. It could also be due to environmental issues as well. How do you treat that? You can treat it with a cochlear implant. So I'm going to show you a cochlear implant in a little bit. Conductive hearing loss, depending on how bad it is, you could do like hearing aids. A hearing aid is basically just an amplifier. Have you guys ever like seen somebody like with a hearing aid that just started whistling, like high pitched, right? You can control the sensitivity, and then sometimes it feedbacks. If it's turned too loud, sometimes it starts feedbacking, and you can hear it as like this loud whistling sound. It's awful. So like the screeching sound, but it's because it's an amplifier. It's like a microphone and amplifier. That's all it is. Whereas cochlear implants, a little bit different. I'll show you what that looks like in a little bit. So super cool. So this is how you diagnose different types of hearing losses. Again, Weber and Rene test, which I'm upset that I didn't bring my tuning forks. But with the Weber test, you're looking for localization, so lateralization. With the Weber test, you put the tuning fork right in the middle of either the glabella or towards the top of the forehead where the bone is, on the frontal bone. And you want to be able to hear the sound equally in both ears, right? If you have unequal in either ear, that means that there's something going on. So normal, your sounds are equal. Abnormal would be louder on one side. And the side that's louder, that's going to be referred to as a conductive hearing loss, versus the quieter side. The quieter side is going to be a sensorineural hearing loss. Now, with the Rene test is kind of interesting. You're supposed to hear bone conduction louder than air. It's the opposite. You're supposed to hear air conduction louder than bone. Now, what you do is you hit the tuning fork, you put it up to the patient's ear until they stop hearing the sound, and then you go to their bone and see if they can still hear it. And so you'll be able to see air conduction versus bone conduction. So with the Rene test, sensorineural hearing loss, you would see more air versus bone, versus conductive hearing loss, you're going to see more bone versus air. So let's just watch a little video on this, maybe explain it better than I just did. Kind of fumbled around there. So these are the different types of tests you can do. And then I'll bring those tuning forks next time so we can do this.
Final year medical students, could I just confirm your name and date of birth, please?
Sure, it's James, 13th of December 1989.
Nice to meet you, James. Today I'd like to examine your ears. This will just involve looking inside the ears with a piece of equipment called the otoscope, and then using a number of different tests to examine your hearing. Would that be okay?
Yeah, that's fine.
James, I'm now going to start with a simple hearing test. I'm going to stand behind you, and I'm going to speak 3 different numbers into each ear. I want you to repeat them back to me when you hear them. 66.
66.
43.
43.
71.
71.
66.
66.
41.
41.
23.
23.
I'm now going to place this tuning fork in the middle of your forehead. Let me know whether you hear it loudest in one ear, or the other, or the middle. I'm now going to place this tuning fork on the bone behind your ear. I'd like you to let me know when you can no longer hear the sound.
Yeah.
Can you hear it now?
If you enjoyed this video,
So air conduction should be louder than bone conduction in that case. So we'll do that on Thursday with the tuning forks. So I should probably make a note of that just so I don't forget. Okay. All right, so again, Weber test, lateralization, Rene test, you're trying to see the difference between bone conduction versus air conduction. Air conduction should be greater than bone conduction. If bone conduction is greater than air conduction, that's a conductive hearing loss. Now, sensorineural hearing loss is the most common of all the different hearing losses. It could be due to the cochlea, it could be due to the cranial nerve 8, vestibular cochlear nerve. doesn't develop rapidly. It develops over time. You start having difficulty hearing voices, and you especially have a difficult time hearing high frequency voices, high pitched voices, right? Women's voices, children's voices, those are the ones that start going first, right? You can hear more lower frequency voices better. This especially happens when there's more background noise. So I'm sure a lot of you have had relatives that have had this, right? Where you go to dinner with your grandpa or your grandma, and there's like a lot of background chatter, and they're having a really tough time understanding what people are saying to them. So a lot of us have experienced that before with a relative. Presbycusis, again, that's just getting old. That's what presbycusis means. There's also Meniere's disease. Meniere's disease is a condition where you have too much lymph in the cochlea, right? So in other words, you have too much fluid in there, and it's going to cause some issues with hearing. You can get tinnitus from that. You can also get vertigo from that. So we'll talk about Meniere's disease in more detail when we get into like the vestibular system next time. Again, loud noises, aging, genetics, diseases can also cause this too. Rubella can cause this. Low birth weight can cause this. Drugs like aspirin, cisplatin, quinine drugs, right? Streptomycin, gentamicin, so aminoglycosides. Lots of different medications can cause tinnitus. Presbycusis, again, this is age-related. It's happening to both sides of the ear, so it's bilateral. This is the most common. As we get older, we just, some of us just lose our hearing, right? Especially if like earlier in your life, you listened to a lot of like loud music, or maybe you worked in an industry that was very loud and maybe you didn't have adequate hearing protection. And so you start seeing decreased ability to understand speech, and you start having a difficult time hearing those high-pitched frequencies. So I'm going to play this video in a second, and this video is awesome. Again, this happens mostly to older individuals, so once you're over 75, 50% of people are going to get this. You can use hearing aids or cochlear implants to be able to treat that. Yeah.
I was thinking a lot of hearing loss, I feel like are going to happen to our generation because of Bluetooth.
Oh, because of headphones?
Yeah, because no one ever had it before us, and now they're like Bluetooth, and they get really loud. So I feel like the only way we're going to see and hear is through our generation.
Yeah, maybe. I mean, but people have been blasting music in their ears for decades, right? Like you can listen to a phonograph with headphones on, like play it really loud.
Yeah,
Right?
not through Bluetooth.
Yeah, I guess you're not. I guess if you have Bluetooth, you're just walking around with like your headphones in, you're probably listening to music more often than not, right?
Yeah.
So yeah, it's possible. I mean, I'd be curious to see what that would result in over time. So it'll take a while for us to get there, though, especially for you guys, you youngins. Yeah, most of y'all are like what, early 20s. By the time you're 75, and I'll be dead.
Yeah, probably.
I'd be surprised if I made it past 50. My dad is 94. That's true. Yeah, that's true. He's an old dude. What did I just do? Hold on a second. All right, let me click on that link again. So this video is really cool.
We've gathered a group of volunteers ranging in ages from 8 to 71 and are putting them to the test in our first Battle of the Ages contest. All right, you guys, I'm going to play a series of sounds. And if you can hear the sound, I want you all to raise your hands up. Your right hand, you're going to keep it there, all right? For those of you watching at home, feel free to play along. Ready? 8,000 hertz. All right. All of you can hear that first frequency. I'm going to play another sound in another frequency. If you still hear it, keep your hands up. If you can't, bring your hand down. 10,000 hertz. Okay, we seem to have lost our 60 and over crowd. You guys look great, though. Let's raise the frequency even more. 14,000 hertz. Okay, we lost you. You're very fit, I can tell. 16,000 hertz.
I can't hear that, can you?
Okay, at 16,000 hertz, we've lost all of our grown-ups. But we still have our youngest members of the crowd with their hands up. Luke, tell everybody how old you are. 8. 8 years old. Fresh ears. Still can pick up these faint frequencies. Nice work. Now we're taking it up to 18,000 hertz. You guys ready?
Can you guys hear that?
18,000 hertz. We've lost 23 and 19, but the under 18 crowd is intact. 18,000 hertz. That's pretty impressive. Enjoy it while it lasts.
So, how about you at home? Were you able to pick up that final tone, or were you left listening to the sound of silence? Well, either way, you may have noticed a trend. As this chart shows, the higher the frequency, the younger you typically have to be to hear that sound. So why is that the case? And what does it have to do with your brain? To help answer that, here's Yale University's Brian Scholl.
Sounds out in the world are just vibrations in the air. But what we hear is determined by patterns of neurons firing in our brains. So the first step in hearing a sound is to somehow translate an air vibration into an electrical neural signal. This is done by microscopic hair cells in our ears. Different hair cells are activated by different frequencies of vibrations in the air. But as we age, these hair cells start to deteriorate so that we gradually lose the ability to hear these frequencies.
What?
And who knows, your kids could be using a high-frequency ringtone
I'll take that.
without you even knowing. So the first point in our Battle of the Ages goes to the younger brain. But this next game is going to come down to experience.
All right, that's enough of that. So you guys heard every single one of those frequencies?
But the last one was really
faint.
Yeah, mine, like, it was 14,000. I can faintly hear it a little bit. I was, like, playing that to my wife the other day, and she could hear basically what you guys could hear. And she was like, you can't hear those? I'm like, nope. Too much rock and roll, man. Too much blasting my amp, pissing off my neighbors, but also simultaneously destroying my hearing. Here's Meniere's disease. Again, this is excessive amount of fluid accumulating within the cochlea and the vestibule. This has a triad. So you lose your hearing, you also get tinnitus, and you also get vertigo. What's vertigo? That's basically the world spinning around you. I'm going to skip playing that video just for the interest of time. This is sensory neural hearing loss, right? So you're losing the neuronal components of your hearing. These patients will also feel a sense of fullness in their ears, so they'll feel a little bit of pressure. It can be unilateral or it can be bilateral. The vertigo, when you feel like the world is spinning around you, you're also going to feel really nauseous, right? It's like being on a boat, right, with really bad waves, right, or being in an airplane with really bad turbulence, right? You might get a little bit of nausea and vomiting.
Is the age of onset still 40 or 60 years old, even if it was caused by like low birth weight or rubella during pregnancy?
This is on average,
Okay.
right? This is averages. There's always going to be outliers, right? There's like a condition called Henoch-Schönlein purpura. Usually happens to children, like young children. There was a student of mine who got diagnosed with it at the age of 21, right? Rheumatoid arthritis, it's usually within 30s, 40s, 50s. I have a student of mine in my pathophysiology class who's like probably 20 years old, and she's had rheumatoid arthritis now for like 8 years. So there's always going to be outliers, right? So this is just average. So yeah, so that just gives you just guidance, but know that there's going to be people that fall out of that. Yeah, so many different factors come into play. Could be genetics, could be other things, right? Avoid caffeine, avoid alcohol, nicotine, salty foods, right? Because salt especially is going to increase your fluid volume. Conductive hearing loss, this happens less than sensorineural hearing loss. Sensorineural is like 90%, conductive is 10%. Symptoms, difficulty hearing, there's going to be voice changes, pain sometimes, right? So it might be easier to hear one of the ears versus the other, right? This could be due to a couple different things. Otitis media. Otitis media is just a middle ear infection. We're going to talk, I put a slide on here towards the very end about otitis media. Bacterial infection. Right? Different types of bacteria can cause it. Haemophilus influenza, Streptococcus pneumonia, lots of different bacteria can cause that. Autosclerosis, which I'm going to show you in a second. Autosclerosis, that's where you have the bones in your middle ear are ossifying, especially the stapes, and it basically prevents the ability for sound waves to be conducted through vibration. Earwax can be another common cause of this, right? fluid in the ears, foreign objects. I'm going to make you hate me right now. This one is awesome. Look at those guys. It's not just a spider, but also molted. So it's got like its exoskeleton in there. That happens. That definitely happens. The first time I saw that particular video, I think it was on Medical Talks. I don't know. I like spiders. I think they're kind of cute, especially the jumping spiders. They're not really like bad for you or anything. But with that patient, they were saying that she like could hear this like scratching sound in her ear, so that's why she went to the doctor to get them. Yeah, they definitely found something indeed. All right, so autosclerosis, you get these like bony growths that start obstructing the stapes. There's a really cool procedure called a stapedotomy, where they go in, they literally cut the stapes, and they basically implant like a little wire with a hook that can attach itself to the incus. So let's watch a little video on this. It's very neat. So this one I don't believe has narration to it. But they'll go in, they'll cut through just outside of the tympanic membrane, and they'll reflect that area so they can get access to the stapes. Stapes also referred to as the stirrup. They'll remove that. And they literally just attach a hook with a wire. So now you can get the vibrations transmitted through the middle ear. So super, super cool procedure. So that can help to bring back a person's hearing. So really, really neat. So autosclerosis, again, it's going to be bony growth, right? Too much bony growth affecting those ossicles, right? The stapes over here in particular. This happens for whatever reason, mostly to women in their 20s and 30s. So this can happen bilaterally, so both ears. So you get progressive hearing loss, and this is considered, in that case, can be considered a conductive hearing loss. So here's a hearing aid. Like I said, it's just literally a speaker with an amplifier, right? The speaker's on the outside. It's like a microphone. So the microphone on the outside perceives sound and it just amplifies it through a speaker on the inside. So here's a cochlear implant. So this is a little bit different. I'm sure some of you guys have seen folks with this. Right? The first time I saw this, I was actually in Bisbee, and the guy had the device it's like posterior, superior to his ear. So the device, basically, there's an external device, which is the microphone, and then you have a wire that goes all the way down into the cochlea. So it can transmit sounds that are picked up by the microphone, transmit those all the way down into the cochlea so you can actually hear again. So that's a really, really cool procedure. Let's watch a little video on this.
A cochlear implant is an electronic device that can restore sound perception in people with certain types of severe hearing loss by picking up sound from the environment, converting that sound into electrical impulses, and transmitting those impulses directly to the auditory nerve. Cochlear implants provide an option for hearing restoration in patients who have more extensive hearing loss, and for whom a device that simply amplifies sound, such as a hearing aid, may not be as effective. A cochlear implant is an example of a neuroprosthesis, as it replaces the disrupted functionality of the cochlea with an electronic device to restore functional hearing. Cochlear implants consist of both external and internal components. The external component typically sits behind the ear and picks up sound through a microphone. When sound is detected, a sound processor converts the auditory information into a radio frequency signal. The signal is transmitted to a receiver implanted under the skin behind the ear. The receiver decodes the signal, then converts it into electrical currents, which are sent along wires that have been surgically inserted into the cochlea. The wires stimulate the auditory nerve, a job typically reserved for the damaged cochlear cells, and stimulation of the nerve causes auditory information to be sent to the brain to create sound perception. A cochlear implant does require surgery, but major complications are uncommon. Studies have generally found cochlear implants to be beneficial, but the extent of the benefit does vary depending on the patient, with children who get cochlear implants earlier and adults who get them soon after hearing loss typically experiencing the greatest benefits.
Do people who get cochlear implants usually get them on both sides or just one side?
It depends, right? If there's one ear that's affected versus both ears being affected. There's a guy that I follow who's a guitar player. He was born with a genetic disease. I forget what it was, but he was born without an ear on one side. So he actually had like a surgical implant, right? So he had a cochlear implant on one side of his ear, not the other side. So some people get it unilaterally, some people get it bilaterally. I guess it just depends. So here are some of the main structures of the ear, so in more detail. So the auditory meatus, right? That's basically what focuses. It's like think of it as being a funnel, right? It funnels different types of sounds, which are just vibrations in the air. You have pinna and you have your concha. So your pinna is going to be part of the outer ear. Concha is going to be more on the inside. And then you have the external auditory meatus, which is just a tube that reaches the tympanic membrane. From the tympanic membrane, when the tympanic membrane vibrates, it's going to first vibrate the malleus vibrates the incus, and then the stapes is going to be the last one before you get into the cochlea. So we're going to get into that in more detail in a second. A couple other things to take note of. There's two muscles that you have over here. You're going to see a tensor tympani, which is going to stabilize the tympanic membrane. And there's going to be another muscle that stabilizes the stapes. And both of these muscles are going to be involved in protecting the ear from really loud sounds. So we'll talk about that in more detail later on. So again, tympanic membrane is what captures those vibrations, transmits those vibrations through the different ossicles within the middle ear until it gets to the cochlea, which is part of the inner ear. Another kind of cool thing about the cochlea and the inner ear, this is all embedded within bone, right? The semicircular canals and the cochlea, that's all bone. Those are bony structures that are basically filled with fluid, hair cells, right, and other structures that help to pick up on sound as well as vestibular perception of like posture, orientation in three-dimensional space. So we'll talk about that next time. So middle ear is to match, they call it low impedance airborne sound to higher impedance fluids, right? So you're getting air conducted into fluids that you find within the inner ear, i.e. within the cochlea. So you're going to have vibration of the stapes at the oval window. The oval window is where the stapes attaches itself to the cochlea. So here's the cochlea. In this image over here, they unwound the cochlea, but the cochlea has like a Fibonacci sequence type shape. It looks like a snail shell, right? And so if you unraveled that, then you can see different regions are going to pick up different frequencies. So the closer you are to the oval window, the higher the frequencies you're going to be interpreting. The further you are from the oval window, the lower the frequencies you're going to be interpreting. So in other words, as you increase the distance, the frequencies are going to be more of a lower frequency. Any of you guys play guitar or bass or any stringed instrument? Yeah, maybe? No? You do? Right? So if you have if you strum your guitar open fret, is it going to be lower or higher pitch? Yeah, lower pitch, right? If you go an octave up on your E string, right, that's going to be a higher pitch, right? So similar to this, right? The longer the string is, the lower the vibration, right? The shorter the string is, the higher the vibration. That's why ukulele has a much higher sound. Why a violin has a much higher pitched sound compared to like a viola or a cello or a bass, right? So same thing that's going on over here with the cochlea. Higher pitch and closer proximity to the oval window, lower pitch, further distance away from the oval window. And then also in their textbook, they give a really nice graphical representation of those different frequencies, right? Higher frequency compared to lower frequency as you move further away. What are the structures in the cochlea that are going to be perceiving sound? So you have couple important structures. You're going to have the tectorial and the basilar membranes. So the tectorial membranes are going to be coming in contact with your hair cells. And then you have the basilar membrane, which is below that. The basilar membrane is going to be associated with the cochlear nerve. Right? So the basilar membrane is basically going to send signals to the cochlear nerve. Let's move on here. Now, as sound is being produced, as vibrations are taking place, that's going to be causing movement of the tectorial membrane. And so as the tectorial membrane moves, it's going to bend those hairs, right? And as those stereocilia bend, you're going to see ion channels opening up, allowing for ions to come inside. And then that's going to basically depolarize those cells, sending signals that eventually make their way to the cochlear nerve of the vestibular cochlear nerve. So you bend those stereocilia, those are your hair cells. Displacement of those stereocilia is going to affect what kind of sounds you're going to be perceiving. So you have different sets of hairs. You're going to have ones that are called the outer hair cells. They're going to come in threes. And you're going to have the inner hair cell, which comes in one row. There's a one row of inner, 3 rows of outer. The inner cells are going to be receiving sensory input. The outer cells are going to be receiving efferent inputs. So there's going to be some cross communication. So it's like a two-way street, basically, in terms of like information being sent to and from the brain. There's going to be top links which connect those stereocilia. And those top links, whenever they get affected, they're going to all move basically in unison, allowing for ion channels to all open up. So here are the hair bundles and the cochlear hair cells. They're all going to be linked together mechanically. So here's the image of those top links. So whenever you move the tallest of the stereocilia away from the other stereocilia, that's what basically opens up those ion channels. When you open up those ion channels, potassium is what enters in. There's going to be a lot of potassium within the fluids within the cochlea. So as potassium enters in the cell, that's causing the cell to depolarize. And then down at the body of the cell, you're going to have voltage-gated calcium channels opening up. And when those calcium channels open up, that's when neurotransmitters actually get released. And then that's going to send afferent signals to the brain. So that's how you're interpreting sound. Again, deflection away from the tallest stereocilia. That's what opens up those cells. That's what opens up those potassium channels. So depolarization, that's going to happen when you move the tallest stereocilia away from the hair cells. You get hyperpolarization if it goes in the opposite direction, right? It's going to close those potassium channels, and then the cell is going to hyperpolarize. You have lots of potassium, right? There's a huge concentration gradient. So the endolymph is going to have a lot of potassium. The perilymph is going to have less potassium. Whenever those potassium channels open, the potassium enters into the cell. This is FYI. I'm not going to test you on the frequency-dependent characteristics of receptor potentials, right? It's good to know that frequencies is going to be demarcated by hertz versus amplitude is decibels. These are the different types of genes that could be involved in hearing. Again, if you're interested in this, cool. I'm not going to hold you guys accountable for any of that. Sound and distortion and chords, right? So chords are combinations of tones. A chord can be anything from 2 notes to 3 notes, 6 notes, whatever. Multiple notes, all having different frequencies, right? That's basically what a chord is. Those top links that are connecting the stereocilia, that's what basically increases the sensitivity to sound vibrations, right? They add springiness, I guess, is one way to think about it, right? Whenever they move, they all basically open up together, right? When you have movement of the stereocilia, you're going to get depolarization at higher rates. Autoacoustic emissions, these are sounds that are generated from the actual ear itself, from within the inner ear. And autoacoustic emissions can actually be used in hearing tests. So as we close out today, let's go ahead and watch a video. Actually, no, never mind. We have 1 more minute left. We'll watch this next time. This is where we're starting when we meet on Thursday. All right? Okay. I brought them. So I brought the tuning forks. So there's 3 different types of tuning forks here. There's the bigger one is going to be lower or higher frequency? Lower frequency, good. So it's kind of like a guitar string, right? The longer the guitar string, the lower the frequency. So this is C, it's 128. Here's C 256, so it's twice, so it's an octave higher. And then this one is C512, which doesn't really work that great for any of these types of studies. The ones that have the little weights at the end, those ones reverberate a lot better. So when you're doing the Rene and Weber test, you can either tap it on your hand. Some people flick it. And some people, like you saw in that video, they just hit it on their knee, right? And so for the Rene test, you can either put it on your nuchal process right here in the back of your head, or you could put it in the front of your head here. You could either use the glabella, which is between your eyebrows, or you could go at the top of your forehead. It really just depends. Some people even go to the top too of the skull. So like any of these spots could really work decently. So it really just depends on what you feel comfortable with. So that's for the Rene test. That's for the Weber test. So you can see lateralization. So if you hear one side louder than the other, then you have a problem of some sort. Do you guys have any earplugs? Like even headphones, maybe like you guys have like portable earplugs that you can put. You can even try to like put an earplug in one ear to see what effect that's going to have on lateralization. And so you're looking for conductive versus sensorineural hearing loss. If it lateralizes to one side, if you have conductive loss on one side, you're going to experience that in the same ear. If it's sensorineural, you're going to see loss in the opposite ear. Now, if it's for the Rene test, air conduction should always be louder than bone conduction. So the way that you do the Rene test is, again, you hit it, and then you're going to be placing it over the mastoid process behind your ear. So that's like kind of a little bony prominence that sits right behind your ear. And you use the base of the tuning fork. And so you have the person listen to it. Once they stop hearing it, you have them raise their hand, and then you shift it over to air conduction. So you put the little weights next to their ear. Okay? So partner up. And maybe since there's only really like 2 good tuning forks, maybe do 2 groups of, or a small group today. 1, 2, 3, 4, 5, 6. So 2 groups of 3. So get into 2 groups of 3 and then just do both of these with each other. And if you have, like I said, headphones, put a headphone in. I have earplugs, but they're mine and I use them. You could if you want to. Yeah, go for it. It's up to you guys.
What are you hearing?
But you do it to each other. You gotta do it to each other, not to yourself. So
why don't you do one example?
Okay, sure. Roy, you'll be my test subject. All right, so the first one I'm going to do is the Weber's test. I'm probably just going to do it to the back of your head over here. And the idea is if you hear the sounds equally in each ear.
Yep.
Yeah. Do you have headphones that you could put in?
I only have these.
Oh, you do? Okay, never mind. So, yeah, you do that on yourself. So long as you hear it lateralized equally, the Weber's test, then that's fine, right? That's a normal Weber's test. Now, the other one I'm going to touch the bony process here. That's the mastoid process. Okay. And then you're going to raise your hand as soon as you stop hearing the sound, okay?
Good.
Ready? Could you hear that still?
Yeah, for a split second.
Split second. Okay, that's fine. Okay. This is a smaller one, so it's not going to reverberate as long. Okay. And so that's totally fine. Okay. The bigger one, you'll hear it a little bit longer. But in general, you're supposed to hear air conductance greater than bone conductance, right? So go, yeah. Yeah, so the bone conductance will last shorter, right? Once that stops, then you shift over to air conductance. You should still be able to hear it. If you don't, then there's some sort of issue. So, yeah.
All right.
I'll give you guys like 5 minutes to tinker away with all that. Cool. So, I'll take those back unless you guys want to keep on making music, right? So, pretty cool. Especially that these are an octave apart, kind of neat. So where were we? We were on slide 37, if I remember correctly. Let me just... All right, yeah, so this is where we stopped. We were talking about autoacoustic emissions. Now, autoacoustic emissions, that's the actual sound that's made by your inner ear. And this is something that you can actually use in like auditory testing. So you can actually see if the inner ear is making sounds, that's a good sign. Sounds that are generated from within the ear, they're going to be generated by your hair cells. Also, other things that are involved are going to be the muscles that control your stapes. So you have the stapedius muscle and the tensor tympani, which is going to stabilize the tympanic membrane. Those are going to be controlled by the facial and the trigeminal nerves. So I'll play a video for you guys in a second, but for the facial nerve, it's the one that's going to control the stapedius muscle. And it's the muscle that stabilizes the stapes, right? That's that little stirrup. Some people call it the stirrup, right? Because it does look like a stirrup. If you ride horses, or you put your feet in there, right? It's the exact same type of shape. The trigeminal nerve is going to control the tensor tympani muscle. Now, I don't know if you guys have ever gone shooting before, but if you ever shoot a firearm and you're not wearing earplugs, you are going to notice these muscles operating in your ear. When I first got my 45 years ago, I was eager to go take it shooting, and I forgot to bring earplugs. And I drove all the way out in the desert with my best friend's dad, and I was like, I forgot earplugs, and he's like, well, let's go for it. And I was like, okay. First round shot, my ears just went numb. Like you can barely hear anything. And that's exactly what these muscles do. They do that deliberately to protect from really, really loud sounds. So it's actually a protective mechanism. So it's perfectly normal for that to happen. Otherwise, you would get rupturing of your tympanic membrane, maybe even damage to those bony processes in the ear, the ossicles. So let's watch a little video on autoacoustic emissions and how this is used in the clinical setting.
It's the only test that actually tests the efficacy of the outer hair cells within the cochlea, which form an essential part of providing us with the very best of hearing. So the outer hair cells, which are the little tiny motors in the cochlea that generate the sounds that we measure with autoacoustic emissions. Those motors give us the really good threshold of hearing that we have, and also our ability to discriminate frequencies really clearly. And so the OEEs are the best method to just check that they're working normally. If that all works okay, then you work further into the hearing pathway by using the next tests, audiometry and speech and noise tests, etc. So it's an essential part of the test matrix.
Cool. So again, this is just used in clinical practice to actually be able to diagnose if a patient has any sort of issues with their hair cells or anything that's going on in this process. Yeah.
So the hair cells are always making noise, just like based on their...
They are, so the brain basically is going to be sending signals to modulate sounds, and it could also involve the contraction of those types of muscles. And it's going to help modulate sensitivity to sound. But you're also going to see those sounds being produced after an initial sound takes place. So over here in C, this is the ear-generated sound that's displayed on this graph. So let's just read through it together. When a brief auditory click is delivered, so you're producing a sound for the patient to hear, the outer hair cells are going to continue to respond to that stimulus, basically. Basilar membrane continues to oscillate, and these are considered now the cochlear generated vibrations, right? And so it's like a continual vibratory sound that is produced even after the original sensory stimulus took place, right?
So they're just like matching the sound that you produced?
It's like outer cells are going to amplify the responsiveness. So it's like you hear the original sound, and then it's basically kind of like modulating the actual sensory input. Does that make any sense?
By sensory input, you mean like the action potential that's generated?
Right. So when you first hear the sound, you get an action potential generated. But then as the mechanisms within the ear continue to respond to that one initial stimulus, they're going to continue to make noises, right? So that's why it's autoacoustic emissions, right? So they're emitting the sound from the organs within the ear, right? And that's going to be a marker of like normal, healthy hearing, right? If you didn't have the autoacoustic emissions, then that means that there's something actually wrong. It means that there's some sort of damage within the structures of the ear.
So if your ears ringing, would that be an example of an autoacoustic emission?
Not quite. That's called tinnitus, and tinnitus is pathogenic. And there's a bunch of different types of conditions that can cause tinnitus. We're gonna. Inner ear. Yeah, so mostly involving, like for example, Meniere's disease. It's going to be like you have too much fluid within those structures in the inner ear, the semicircular canals, as well as within the cochlea. And there's also conditions that affect like the nerves, right? So if you have like an acoustic neuroma, right, a tumor that's growing on cranial nerve 8, that's going to cause tinnitus. And so tinnitus is not part of this process. It's not like it's not a marker of health. It's actually pathogenic. It means that there's like an underlying disease process taking place. Moving on. So here are different pathways that are involved in the hearing process. And I am not going to hold you guys accountable for all of these processes, but we can go through them together. So you have your inner hair cells, right? And then when they get stimulated, they're going to allow for transmission to the cochlear nucleus. And the cochlear nucleus is going to send signals to the medial superior and lateral superior olivary nuclei. And those are going to be found within the brainstem. And then those are going to also communicate with a couple other regions, the trapezoid body, as well as the medial geniculate. Again, I'm not going to test you guys on these different pathways. There's a lot of different pathways involved in hearing, but this is part of the ascending pathway. And then in the brainstem, you're going to have 3 different divisions. So that's going to be in the part of the cochlear nucleus. Anteroventral, posteriorventral, and dorsal. Again, I'm not going to hold you guys accountable for these different structures or pathways, but let's watch a little video that breaks this down.
How do signals travel from hair cells in the organ of Corti to the primary auditory cortex? Well, let's examine the ascending auditory pathway. Why ascending, you ask? Well, ascending means information goes to the brain, while descending means information goes from the brain elsewhere. Inner hair cells in the organ of Corti are connected to type 1 spiral ganglion neurons, whose axons represent 95% of the cochlear nerve. So firstly, signals travel along the cochlear nerve to the cochlear nuclei in the brainstem on the ipsilateral side. Ipsilateral means same side, and contralateral means opposite side. Here's where it starts to get a little complicated. Most auditory information crosses over. However, each cerebral hemisphere processes stimuli from both the ipsi and contralateral sides. This is advantageous for 2 reasons. First, if you get brain damage in one hemisphere of the brain, your sense of hearing doesn't suffer much. Second, as humans, we process some pretty complicated sounds, like those involved in speech, and getting input from both ears to both hemispheres allows for more processing potential. Anyway, back to the ascending auditory pathway. Our information is at its first stop, the cochlear nucleus. From here, most of the neurons cross over to the contralateral side. This is the primary pathway that the information takes. However, there is also a secondary pathway in which some neurons stay on the ipsilateral side. In both cases, the neuron synapse in the superior olivary complex, which is also in the brainstem. The signal continues to be relayed along the lateral lemniscus to the inferior colliculus in the midbrain. From the inferior colliculus, the information is relayed to the medial geniculate nucleus of the thalamus. Most of the neurons taking this trip stay on the ipsilateral side. However, some cross over. Finally, the information continues into the auditory cortex. The auditory cortex is tucked into the lateral sulcus. The auditory core region contains the primary auditory cortex, or A1, which is organized tonotopically. In other words, it's arranged by frequency. There are actually tuned neurons that respond only to specific frequencies, and they are arranged in a tonotopic map. How cool is that?
If you like this video, please like and subscribe. It would help me make more videos. And make sure to comment with any topics you'd like me to cover.
Okay. So that was a really, really great breakdown of all the different pathways involved in hearing. So again, you get both ipsilateral and contralateral, and this is part of the whole ascending pathway. But I'm not going to test you on all those different, regions within the brainstem and that whole entire pathway. But know that, both sides, you're going to get information coming in from both sides that can be processed in the brain, and that basically helps to protect against any loss of function from damage. Inferior colliculus, we're going to talk about the inferior and the superior colliculus in a little bit, but both superior and inferior are going to be involved in auditory processing, but the inferior colliculus is mostly involved in auditory processing. When we get into the connection between the superior colliculus and vision and hearing, like there's a connection there. Right. So superior colliculus, you mostly associate with vision, but there's also going to be some auditory intermingling in the superior colliculus. But think of the inferior and superior colliculi as being kind of like a relaying center to help processing information, particularly the type of information that you really should pay attention to from the environment. And again, be familiar with which nerve innervates which of the muscles. So facial nerve, stapedius, and then trigeminal, the tensor tympani. So again, you have multiple different regions that are going to be all communicating with each other to help process sound, process complex auditory information. That's all going to be sent to the primary auditory cortex. This is also referred to as Heschel's gyri. But for this class, I'm only going to refer to it as the primary auditory cortex. Now, if you want to actually find that primary auditory cortex, you literally have to pull apart the sylvian fissure to be able to see that. It's deep within those structures. The secondary auditory complex is a little bit more superficial, and so that's going to be superficial to the primary auditory complex, associated with the temporal lobe. And another thing that's kind of interesting too is that if you guys recall, Wernicke's area, which is part of, kind of understanding and comprehending speech, is going to be directly posterior to this. So Wernicke's area is directly behind. So whenever you hear speech, words, right, you're going to start getting a little bit of processing of that in Wernicke's area, and it's also going to be associated with the temporal lobe with the process of just sound in general. And so they all kind of cross-communicate. So here's a reiteration of all of that. Now, with auditory perception, there's going to be a couple things that are important, right? The actual quality of the sound, physical quality of the sound, intensity of the sound, the loudness, right? The amplitude, if you were to measure it on a graph. And another thing is perception. So when you close your eyes and you hear a sound, you're able to still determine where the sound is coming from, generally speaking. This is also something that can, if you know anybody that's blind, or you've seen anybody walking with a walking stick, right? Some things that they can do is like tap. They can tap on objects and they can hear the sound just like reflecting off of walls and off of other structures. So it gives them like a mental map of like the topographical layout of where they're at. There's even this really amazing guy. I should probably start embedding him in my auditory lecture. He's completely blind, but he can skateboard. and like really well. He can do actual tricks, and it's incredible to watch. But he skateboards with a walking stick, so he's able to, like, while he's skating, he's able to tap on things, and he can hear the sound reflecting from different surfaces. So he can actually kind of visualize mentally where he's going. So you're able to perceive frequency and location. So let's first talk about frequencies. There's a phenomenon called phase locking. And when you have phase locking, you see this happening at low frequencies in one neuron. It gives you the ability to allow for, like, temporal spacing of a frequency. If the frequency happens at a higher frequency, however, this becomes a little bit more difficult, because you have, like, a higher frequency, you have lots of different waves coming in at a rapid pace. And so you're going to see remember, nerves have an absolute refractory period. So if you overstimulate a nerve, you're not going to be able to get an action potential at a certain point, right? So at higher frequencies, you have to have multiple neurons coming into play to allow for phase locking to occur. So let's watch a little video on phase locking.
Phase locking is where neurons only fire at preferred phase of the sound wave in each cycle. This is usually at the peak amplitudes. At low frequencies, it's possible for neurons to fire action potentials for every cycle. This makes it easy to determine the frequency of the sound, because it's just the same as the frequency of the neuron's action potentials. At slightly higher frequencies, between 1 kHz and 4 kHz, neurons can't fire for every single cycle, because their firing rate is limited by their refractory periods. For example, here the neurons are only firing at 50% of the cycles. The action potentials will still only occur at the same phase of the sound though, which means that phase locking is still in action. If you have a group of neurons, each responding to different phases of the input signal, it's possible to have a response to every cycle overall. Therefore, you'll have a measure of the frequency. This is called the volley principle. Phase locking occurs with sound waves up to about 4 kHz. Above this point, sound waves travel too fast for the action potentials of individual neurons to accurately represent their timing. This is because of the intrinsic variability in the timing of action potentials. It's about the same as a time interval between successive cycles of sound. This basically means that the neuron just ends up firing at random phases of the sound wave. This means that frequencies about 4 kHz are represented by tonotopy alone. This shows how phase locking is important in pitch perception, but it's important to remember that the intensity of the stimulus is encoded by the number of sensory fibers that are active, rather than the frequency of firing. The number of active fibers is linearly related to the amplitude of vibration. Here you can see that the recruitment of more fibers increases the perceived amplitude of the signal.
Super cool.
Okay, so now let's take a closer look at...
Any questions on that? So if you didn't have phase locking, if you didn't have enough neurons able to respond to higher frequency sounds, you're just going to basically get all sorts of distorted sound perception. Right? You're not going to actually be able to perceive those sounds. And so you'd get effectively destruction of the noise signal, right? Now, as that other video mentioned, you do get a tonotopy, which is topographical areas of the primary auditory cortex actually responding to different frequencies of sound. And that video that I played earlier did a great job, like literally like playing the piano notes associated with like different regions, going from low frequency to higher frequency. So super cool that different regions in the primary auditory cortex actually do that. So you see specific regions for specific frequencies. Moving on. So this is all FYI. This is like different studies that basically looked at the ability for perception of different sounds. Right? You can see different regions that are going to be affected in the brain and how they respond to different frequencies. So you can read that in more detail on your own if you would like. I'm not going to hold you guys responsible for any of that. This was recorded from the inferior colliculus, Now remember, inferior colliculus, that's auditory processing, or one of the regions that are going to be responsible for, transmitting auditory signals. And there's going to be a range of frequencies where you can see the individual being sensitive. Remember, different animals are going to be sensitive to different ranges of sound, right? Humans are going to have a different range of sensitivity than monkeys in this particular study, right? Same thing with like animals in the ocean versus animals like, birds and whatnot. They all respond to different frequencies. And here is another study that they were talking about different types of tones. So they were looking at pure tones, and pure tones are not going to, pure tone is just like one individual sound frequency, right? So if you hit this tuning hammer over here, that's a pure tone, right? It's not complex. It's one simple frequency, one simple note. If you have more complex sounds, maybe you're listening to music and now you're hearing two tones, right? If you hit both of these, now you have one that's an octave higher and you have one that's an octave lower, right? And so now it becomes more complex, right? Speech is the same way. Music is the same way. Complex sounds are all going to be the same way. So you're going to have more like complex processing involved in those types of complex sounds. Now, here is, again, study looking at simple sounds versus more complex sounds. The more complex the sound begins, the more difficult it is to actually predict firing patterns. That's what's going on with this bottom chart over here. You're not able to actually predict the firing pattern with more complex sounds. That's going to be something that you can only do with like more simple types of tones and frequencies. They become more predictable, whereas it becomes more difficult once you get more complexity involved. Now, in terms of localization of sound, right, that has to do with a couple different things. It has to do with timing, right? Timing differences, like how long it takes for a sound to hit one ear versus the other ear, right? And so timing is going to be important. In other words, if a sound occurs to my right ear is going to perceive that sound first until the vibrations reach my left ear. And so timing is going to be really important. Leveling is also going to be important. So leveling, for example, so loudness differences are going to be affected by structures, like structures in your face, structures in your head, your nose, right? And this is going to occur on a horizontal plane. Now, spectral cue, this is going to involve both horizontal perception of sound versus vertical perception of sound as well, right? So in other words, if a sound comes from above, that's going to be involving spectral cues, right? Your brain will be able to perceive that the sound's coming from above versus coming from below. So that's what you mean by vertical access. If a sound comes from left versus right, that's horizontal access. And so your intraoral timing difference is going to be involved in that intraoral level difference. And then spectral cues will be for vertical access. And so you have a cone. They call it the cone of confusion, right? You have your ears basically serve as a funnel, right? So you're basically funneling in sound coming from different areas on a vertical axis. So as these images over here portray, again, intraoral timing, right? If a sound is coming from this person's right side, the right ear perceives it first. Left ear is going to perceive it second. And so you'll be able to localize where that sound is coming from. Intraoral level difference would be due to sound being obstructed by a physical object, aka your head, right? So again, if you have a sound coming in from the right side, you're going to get a little bit of an acoustic shadow, right? Those sound vibrations are going to be obstructed by the actual physical presence of your head. And then versus the cone of confusion, which allows now for more of a vertical axis type of sound. So they call it spectral cues. So here's another way to look at that. So you have spectral cues coming from location A, which is above, versus location B, which is below. And so you can see how the brain is going to have to process where those sounds are actually coming from. in terms of the vertical axis versus horizontal axis. So just be familiar with those like three major aspects of localization, right? Intraoral timing, intraoral level, acoustic shadow, and then conal confusion, which has to do with the spectral cues. Now, different areas in your brain stem that are going to be responding to sound processing. You have a couple areas. We already talked about the olive, right? You have the medial superior olive, and this is going to allow for binaural type differences, right? And so, in other words, localization, right? Which side is being stimulated first versus which side is being stimulated second by a sound. And so it allows you to map the location of the sound. So from this image from your textbook, the sound is reaching the left ear first. And so with the left ear being stimulated first, signals are going to be sent. And there's regions within the medial superior olive in your brainstem that are going to allow for localization, right? So in this case, the path, it took a longer time for the signal to reach the region E, which is on the right side of the medial superior olive. And so just because it took a longer time for the signal to be sent to the region in the brainstem, then your brainstem also has an important role in helping you figure out which side the sound is going to be coming from. So here's another breakdown of what's going on over here. So you have neuron E, so that's going to be this first one on the left, versus neuron, the other neuron coming from the right side. And you're going to see that, the region within the medial superior olive allows for localization, right? Depending on how long the signal gets sent to those different areas in the medial superior olive. Now you have another region as well. This is the lateral superior olive, and this is going to be associated with intensity perception. So medial superior olive is going to be lateralization, localization of sound. Lateral superior olive is going to be the intensity. So stronger stimulus. The stronger stimulus on the ipsilateral side is going to allow for activation of that region, versus the contralateral side is going to be inactivated. So it's going to be inhibited. And so that's basically what the lateral superior olive is doing. So allowing for perception of intensity, which side is going to be louder than the other. So again, excitation from the ipsilateral input will be great, and inhibition from the contralateral input will be small. All right, now, superior colliculus, again, right? Inferior colliculus is mostly dealing with hearing, whereas superior colliculus is going to be dealing with both visual stimulus as well as auditory stimulus. So this is how you get different sensory inputs being able to basically communicate with each other, crosstalk, right? And this is especially going to be important for alerting you to something that you should be paying attention to. So in other words, superior colliculi are going to respond to both visual and auditory stimulation. And this is FYI in terms of like computation within your brain, timing differences, frequency differences. I'm not going to go into this in too much detail, but if you want to read through this, feel free to do so. Now, the last thing I want to cover in auditory is otitis media. Now, this is middle ear infection. Right? Whenever you have a middle ear infection, it's otitis media. And it's going to be due to bacterial infection. There's a handful of different types of bacteria that are the most common in otitis media. Strep pneumo, so Streptococcus pneumoniae, which is the number one cause of pneumonia and the number one cause of meningitis, is also one of the major causes of otitis media. Haemophilus influenza, this one is a gram-negative bacteria that you mostly see affecting young kids. These are going to be children like under the age of 5, right? And these kids are going to be more susceptible to otitis media. And then there's another one too, Moraxella catarrhalis. Now, the main thing about otitis media, especially with young kids, when they can't talk, they're not going to just be like, hey, mom, my ear is hurting, right? The kid is going to look fussy. They're not able to speak, right, because they're too young to speak yet. So one of the big giveaways for a young kid that has otitis media is tugging at the ear. Right? The kid's going to be fussy. They might have a fever, but then if they start pulling and tugging at their ear, that's a dead giveaway that this is otitis media in a child. Obviously, when the kid's old enough, they can tell you what's going on, right? I had an ear infection once in my life. I think I was probably about 5 or 6 years old, and it was really bad. Like one of the most uncomfortable feelings, right? Fullness in the ear, and I was like hallucinating because my fever was so incredibly high. Has anybody in here had a middle ear infection? I feel like most people have at some point in their lives, especially when they're younger. Now, if you have an ear infection, what you look for, you do an otoscope, right? So you go look inside the ear to see what's going on with the tympanic membrane. If the tympanic membrane is normal, like in this image over here on the left, you should be able to see through it a little bit. It should be a little translucent. You should be able to see the malleus because that's the first bone in the middle ear. You might be able to see the incus as well. You're probably not going to see the stapes, right? Because the stapes is a little bit deeper. You could see a little light reflex as well. That's just light coming back from the otoscope. So that's a normal, clear-looking tympanic membrane. If it's bulging and it's got like obvious like purulence behind it, like pus, then you can diagnose otitis media with those patients. This needs to be treated with antibiotics. So these patients should take antibiotics. Why? Why is it really important to treat this? Well, if you could cause, there could be like permanent damage. Yeah, it could travel to the brain. Yeah, so this could easily turn into meningitis. Right? Think about the proximity. Right? It's right there. It's right next to your brain. So this could, and you also got the cranial nerve right there. Right? Cranial nerve 8 leads directly to the brain. So this is scary. Right? This could cause meningitis. Haemophilus influenza is one of the major causes of bacterial meningitis in young kids. Right? Now, some patients have persistent middle ear infections. Has anybody in here ever had that? I've had students in my class. Did you ever have to get a tympanostomy?
I've never had to get anything done, but every single time I go, they're like, this happens to me once a year, probably at least.
Ear infection?
Yeah, I also get strep all the time.
Ooh.
Which is the same. Yeah.
Yeah. Well, Streptococcus pneumoniae is not the main cause of strep. Streptococcus pyogenes is the main cause of strep throat.
Yeah, I don't know. They've always just told me like, yeah, there's probably a link there that you always get this, or like I told you, like I get strep.
Yeah.
And if everything is not perfectly clean, then I get strep immediately after. Like it just seems like it doesn't take much for me to get strep or ear infection.
Yeah. Well, I mean, everything is.
And be like, yeah, I don't know, like maybe you're just like, because I clean my ears really well, but it doesn't really matter.
So I mean, they're also connected too with the eustachian tube, right? The eustachian tube connects your ear, your inner ear, all the way down to your pharynx, and so there's a connection. Like I said, when my wife got, she didn't get necessarily bronchitis, but she got influenza from me over the winter break. She also got a middle ear infection, right? Because respiratory illness can also affect the ears as well. So patients sometimes have to get a tympanostomy tube. These are usually put in place. So I forget which one this was, liquid infused tympanostomy. Generally speaking, they put them in place and then over time they just like fall out on their own, right? And so you usually don't have to get them physically removed. But tympanostomy tubes can be really helpful to alleviate the pressure, right? Also to allow for kind of, I don't know what you would say, like reduce like moisture and like all the stuff that basically lays the groundwork for the infection to really take place. So let's watch a little video on this. So pretty cool stuff.
I'm a mother of a 1-year-old daughter who has had at least 6 ear infections in the last 6 months, which makes her actually one of the potential candidates for ear tubes.
I took this clinical otolaryngology class at Mass Eye and Ear last year where we actually looked inside each other's ears. And when people would look in my ear, they could see scar tissue from actually when I had ear tubes when I was 2 years old.
Tympanostomy tubes, also known as ear tubes, are devices that are placed frequently in children, but also in adults, under conditions of recurrent ear infections, and that is to evacuate fluid that's stuck behind the eardrum or to ventilate the ear in order to prevent recurrent infections from taking place. Current ear tubes, as we know them, are very much unchanged for when they were first introduced about 40 years ago and have had persistent problems.
Sometimes the ear tubes get clogged and administration of topical antibiotics do not make it into the middle ear. They can be prematurely extruded, they can be very invasive and cause perforation, scarring tissues and potential hearing loss. Sometimes they have to be reinserted, which leads to more surgeries under general anesthesia, which are truly undesirable by patients and parents.
And I think that some advances within material science that have occurred over the last few years may be able to address these issues.
We're full of pipes in our bodies, and they are supposed to be friction-free. So nature has evolved already how to make piping non-adhesive to bacteria, non-adhesive to a range of other biological foulants.
Our team leverages unique biocompatible materials and designs, and we utilize an easy to manufacture route through silicon injection molding.
Not only that, it makes the tube non-adhesive to microbes, but it actually creates unique transport properties. In one direction, the tube is capable of releasing tension and otitis media coming off the inflamed area, and in the other direction, to have antibiotics, drugs that can be delivered to middle ear to treat the infections. That is highly unique, customizable feature that has never been seen before.
So this can reduce otorrhea, and this can also prevent premature extrusion of the tubes from the patient, so there's a more predictable time frame.
In vitro results are incredibly promising. We look forward to animal studies through an animal model that's already established, and we hope to be able to consider a human clinical trial in the not too distant future thereafter.
For me, it was very important to work on this project and try to find a better solution available for parents who definitely desire a more reliable medical device implanted into their children's ears.
So super cool stuff. There's always new advancements coming out with different approaches, just piggybacking off of what's already out there, right? But I've known lots of people who've had these tympanostomy tubes in the past, and they seem to be doing pretty well now in adulthood. But like I said, some kids get that, and they get it like very, very frequently, and it's highly problematic. Shall we do like one or two quizzes questions before we move on? Let's do it. All right, let's begin. All right, make sure you know your cranial nerves. Super important. What is cranial nerve for? Yeah, that's cranial nerve is 9. What is cranial nerve for though?
Is it this part of your vision, like seeing by your?
Yeah, being able to look down, basically down and out. So a trochlear nerve. Right, cranial nerve 9. What's cranial nerve 9? Yeah, good. What is cranial nerve 7? Facial nerve, good. So that's going to be muscles of expression, taste in the anterior 2/3 of the tongue. What's cranial nerve 11? Accessory nerve. What does that do? Yeah, shrug your shoulders. Cranial nerve 8. So vestibular cochlear nerve. Okay. So this could be affected in sensorineural hearing loss. You could also get acoustic neuromas. Acoustic neuromas are going to affect cranial nerve 8. And there's 2 components to cranial nerve 8, vestibular and cochlear, right? Which one is associated with hearing? What is cochlear? What does the vestibular do? Balance. Good. Excellent. So I'm going to stop that. You're going to do the rest of these on your own time.